Welcome to Coding for Asthma, the Breathe Alabama Asthma Learning Collaborative coding module. I am Cason Benton, a general pediatrician and director for ACHIA. I do not intend to discuss any commercial products or any non-FDA approved uses of products, and I don't have a relevant financial relationship with any commercial interest. As for a disclaimer, I have put this PowerPoint together to the best of my ability as of October 2017. I appreciate the assistance of coding expert and colleague Lynn Brown, but any mistakes here are my own. And also, nothing that I say today is meant to represent guarantee of payment from any of the insurers. Today you'll learn the appropriate codes for common outpatient asthma-related conditions and learn how to document and code those common visits. As always, it's hard to know whether you should code what you get paid for or code what you do. We recommend coding for what you do because sometimes you can be surprised and something will end up being covered. And also it's good to document to the payers the work that we do in the visits. So what should you code? Diagnosis codes communicate medical necessity, and it's important that you code the most definitive diagnosis as primary. The symptoms that are inherent in the primary diagnoses should not be included, but you should code additional diagnoses that support the level of care. So sometimes you will need to use symptom codes. You may be familiar with the codes for shortness of breath, wheezing, dyspnea, but you need to know about RO 6.03. That is a new code for acute respiratory distress. So it gets away having to use an unspecified code to support your level of care. Now for your ICD-10 asthma documentation, quite a bit more is required than for ICD-9. First, you have to talk about severity. Is it mild, moderate, or severe? As well as persistence, intermittent or persistent. And you need to document the level of exacerbation, uncomplicated, acute, or status asthmaticus. If you have a type such as exercise-induced bronchospasm or cough variant asthma, include that. And if there's some external causes such as tobacco smoke exposure, include that. Now you'll notice there's a disconnect between the coding world and the clinical world. So for example, for intermittent asthma in the clinical world, we don't use the term mild, but you will with coding. And also in the clinical world, we talk about levels of control, well-controlled, not well-controlled, very poorly controlled. And they don't really match up well with the levels of exacerbation. But what I typically do is if something is well-controlled, I consider that uncomplicated. If it's not well-controlled, and for many very poorly controlled, that's going to be in acute care. And then for your status asthmaticus, that's for the medical emergency and a patient who is likely to be admitted. So when you look at your ICD-10 codes, your J45 codes, you see that it has the severity, is it mild, moderate, or severe, the level of persistence, intermittent or persistent, and then is it acute, is it uncomplicated, or is it status asthmaticus? You notice that they do provide unspecified codes, but you want to get away from these and use the more precise ones. Here are the codes for the exercise-induced bronchospasm and the cough variant asthma. And I do want to point out that in the past we would clinically often use the term reactive airway disease. And we typically meant that was for patients we weren't quite ready to declare as having asthma, but may be on that pathway. But when we code reactive airway disease, it is a J45 asthma code. And those patients will be rolled up into any metrics you may have regarding asthma care. And then you want to code any external factors. For here, the most common one is the exposure to environmental tobacco smoke. And so how does this look in documentation? Now when you're documenting the visit, you want to talk about the severity and the persistence, so mild, intermittent. You want to talk about the level of exacerbation. This patient is status asthmaticus. And then you see the external factor of the child being around cigarette smoke is included as well. Moving on to the physician evaluation E&M services. As always, you want to be sure to include a chief complaint, and that is required to support medical necessity. And then what I'm going to focus on is a level 4 established patient visit, because many of our asthma visits do end up fitting this criteria. And for this, you're going to need 2 or 3 of a detailed history, a detailed physical exam, and your medical decision making needs to be of moderate complexity. So let's start with that detailed history. Your detailed history has to have all 3 areas included: your HPI elements, your review of systems, and your pertinent histories. So HPI elements: location, quality, severity, timing, context, modifying factors, and associated signs and symptoms. You're going to need at least 4 of those elements for an acute problem. Or if they don't have an acute problem, you need to be talking about 3 chronic or inactive problems that might be well controlled. A side note, Medicaid does have you document duration, but it's not considered an HPI element in the CPT world. Then, for review of systems for a level 4 established patient visit, you need to cover 2 to 9 systems or body areas. And then for your pertinent histories, you just need to have 1, such as how did you respond to your medications? Did you start daycare? Do any other family members have this condition? And then for your other element that you want to consider for a level 4 visit is a detailed physical exam. So most of us use the 95 guidelines in pediatrics, and for this, for many payers, you need to have 5 minimum areas covered. And when we say detailed exam, you want to avoid within normal limits. They are looking for more detail than that. For those of you who do use the 97 guidelines, you need 12 bulleted elements from at least 2 body systems or body areas. And then lastly, well, let's look at medical decision making, moderate complexity. And here you have to have 2 or 3 of the following: diagnosis and management, data, and risk. For your diagnosis and management, you need to have 1 established problem that's uncontrolled and an established problem that is stable, or 3 established, stable, and controlled problems. So you can imagine having, for example, uncontrolled asthma and maybe eczema. Data, you need to be obtaining the history from someone else, and that's pretty common in pediatrics. We're often talking to another family member, as well as being ordering or reviewing a test. And in asthma, that's not common unless we have spirometry in our office. So usually for our second item, we're looking at risk, and we only need 1 of these. And that would be prescription drug management, a chronic illness which is worsening, or talking about 2 stable chronic illnesses. So to wrap up, if you want to bill a level 4 established patient visit, you need to have either a detailed history, a detailed physical exam, and medical decision making of moderate complexity. You need 2 of 3 of those. However, sometimes you need to do time-based care. Here, for time, that's what you use when your counseling and coordination of care takes more than 50% of the time that you have in the room, and that's face-to-face time by the provider billing that day. And you can include the time it takes to obtain your history, perform your exam, or to counsel the patient. Remember to document the extent of your counseling and coordination. For an outpatient new patient, here are the CPT codes and the amount of time. And these are the CPT codes for an amount of time for established patients. Now, what happens though if your patient, the amount of time is in between one of these? So what if your patient, it takes 13 minutes or 21 minutes? Well, then you bill to the nearest time. So for example, if you're going to bill a level 3 visit, a 99213, that would be any time between 13 to 20 minutes. And a level 4 would be any one time from 21 to 32 minutes. And so, as an example, let's say you're in the room for a total of 22 minutes and 15 minutes has been spent counseling. Well, that's more than half the total time, so you need to use a time CPT code. So the physician here would report a 99214 because the total face time was closer to the 25 minutes than it was to the level 3 of 15 minutes. And remember to clearly document the time that you were in the room. Now there's some additional codes that may be of benefit. The 99050, that's the service that's provided when your office is typically closed. Think about that as when the office is closed and the physician is unlocking the doors to let the patient in. There's also a more commonly used 99051. That's services provided in the office after normal hours. For Blue Cross Blue Shield of Alabama, that is 7 a.m. to 6 p.m. is considered normal hours for all offices. And then there's also a 99058, and that is when you have to completely shut down giving any other patient service while you deal with the needs of one particular high-intensity patient. And then what to do when you're doing a checkup, but you're also talking about a chronic condition? Well, if it's just regular management, you just do your regular visit and code it like that. But if the child is sick, is wheezing, is having trouble, you're changing medicines, you may want to add a sick visit and a modifier 25. Moving on to some medicine codes that your practice may use. If you're performing spirometry, you may want to use the 94010, and there's also a code for pre and post spirometry. Most of us are going to provide inhalation treatments, and we also need to be coding for when we provide education with the 94664. Now, if you're going to give education, you need to document what you did. So talk about the device you used, the patient's understanding of the device, and how did they respond once the education was complete. And remember to use your modifiers. Be aware that the first two, which are spirometry and pre and post spirometry, cannot be billed together. But if you are going to do separate procedures, such as a pre and post spirometry and an inhalation treatment, you would use a modifier a modifier 59. And you want to use a modifier 25, and it is now required if you're going to do any office visit codes 99201 through 99499 if you're billing with a pulmonary code, as you see listed there. What about billing for medications and supplies when you give an inhalation treatment? Alabama Medicaid does not allow you to bill for additional supplies. Blue Cross Blue Shield will allow you to bill for the medications. Now, the way you bill for Blue Cross Blue Shield of Alabama and Alabama Medicaid, if you're giving multiple treatments on one day, is on the same line with the number of appropriate units. You should check with other payers, though, because they will often have you bill on one line, and then each additional treatment will be billed on another line with a modifier 76. Now, for pulse oximetry, many payers roll it up, but there are a few payers now compensating you for that additional service. So do consider including that on your claim. Peak flow, if you want to use it, is an S8110. Not all payers recognize S codes. And then if you're going to use a standardized test, such as an asthma control test, that would be billed with the 96160. That is a validated instrument. You need to document the outcomes in your note. Payment for that is variable as well. So let's try to apply some of these principles to some specific cases. So looking at case 1, this is a 23-month-old that comes in with what just seems like a regular cold, but with just a few additional questions. You find out there's a family history. This patient has used steroids in this year. She has symptoms where she's coughing every night, and she's wheezing on exam. And this patient is moving into that new diagnosis, asthma, that is not well controlled. and it is meeting the criteria for a level 4 visit. For our second case, you have a 7-year-old who comes back in for a recheck of his asthma, and he is actually doing much better. He just needs some medication refills. You would probably bill this as a level 3 and then add on the CPT code for the spirometry, but since you're doing medication management, one could argue a level 4. What about that health supervision exam? A child comes in doing very well on his asthma. You would just bill for a regular checkup here. But the same patient comes in and they are not taking their medicine, they are wheezing, they're using their albuterol every day. You're restarting their treatment at level 3. This one I would bill as a checkup, but also add on the sick visit codes and add on your modifiers. And for case 5, it looks very simple. It's just a 4-year-old with a rash behind her knees, but you start looking into it more and you find out that this patient also coughs with exercise and wakes up every night coughing. And again, now that you've got the eczema and you've got a new diagnosis likely of asthma, this will be a level 4 visit as well. So if you have any questions about the coding, please give them to your core team and we can discuss them on the monthly webinar, or feel free to email me at this email, cbenton@peds.uab.edu, and I will try to find the answer for you. I also strongly recommend you go to the AAP coding resource. It is located on the ACHIA.org website. Now, if you are seeking CME or Part 4 MOC, please return to the post-test and evaluation on the ACHIA website for this module. Thank you.